I'm Michelle Macheski, co-chair for this year's Women's Health and Cancer Conference. I'm pleased to introduce our speaker for this provider track session on having difficult conversations. Stephen Berns is an associate professor in the Department of Family Medicine at the Larner College of Medicine at the University of Vermont. He is also director of education for the Division of Palliative Medicine and the director of Talk Vermont, a multi-component intervention to improve the frequency and quality of serious illness conversations through communication skills trainings for clinicians. Dr. Berns will be available at the end of his presentation to answer questions, which you can ask live by unmuting your microphone or by typing into the chat. Many thanks for joining us. Here's Dr. Berns.
Thank you for the welcome, everyone, and pleased to see all of you this morning. We're going to do a little bit things different because it's a Friday morning and we are all just waking up. We're going to actually be doing a little bit of an interactive workshop where I will invite you to do a bunch of different things throughout the time. So, without further ado, I just want to start with making, there are no financial disclosures for me to make. They're in conflict with today. And I wanted to warm us up in the chat. So if everyone could put in the chat, what is the ice cream flavor that describes your morning or your day? And I'm going to put into the chat coffee, buzz, buzz, buzz. Just invite all of you to find your chat and to put the coffee flavor that describes your day. Fantastic 7-layer bar. Thank you. Twist. A lot of chocolate. Chicken ripple. Ooh, that is a great flavor. Peanut butter, pendulum, mint chocolate chip, definitely coffee. Excellent. Chocolate, green tea. Wow, green tea is delicious flavor ice cream. Mint chocolate chip, lots of coffee, a few others, lemon, espresso chip, any. Ooh, I love the Rocky Road, coffee, maple, toasted coconut. Delicious. Sea salt caramel. Fantastic. You have all found the chat button. S'mores. Excellent. Thank you, Dr. Chesky. Michelle. We are going to then warm us up with the poll feature. So I'm going to launch a poll, and I'm going to ask you all to talk about how confident are you in delivering serious news? And so think about the poll itself. How confident are you in delivering serious news? So hopefully the poll launched and you could actually click on how confident you are. And it's anonymous, so I don't know who answered what. And we'll be using the poll feature throughout today. And I'll wait till at least 60% of you have found the poll button. Excellent. We're at 58%. Amazing. I think we reached 60. Fantastic. Great. So I'm going to end the poll and I'm going to show what we have. So as you can see, majority of you said you're okay at sharing serious news. Some are confident, but have trouble with the hardest conversations. Some are not very confident and run into trouble regularly, and some rather someone else do it. Not too many said, or no one said, I'm very confident and I'm an expert. Well, glad you're all here. I hope by the end of today's session, we will be able to talk a little bit more and give you some confidence in serious illness, delivering serious news to patients and their loved ones. The learning objectives for today are as follows. We're going to talk a little bit about the barriers to sharing prognosis and how we can navigate patient and family goals. We're going to discuss how to start a timely and effective conversation that includes sharing prognosis, and thinking about how that can help us with patient goals and treatment plans. We'll practice how to build a rapport or think about how to build rapport with patients and their families. My caveat is that we can spend so much time on different skills. So for today, we're really going to focus on delivering news or serious news and prognosis. And we'll talk about how that can inform our goals of care conversations. But we are not going to talk about goals of care, mostly because that probably will take another hour to do. And I just want to do a public service announcement. I am a palliative care physician, and for all of us to be on the same page, what is palliative care? Palliative care is a specialized medical care for people with serious illness. We focus on providing the relief from the symptoms and stress of a serious illness. We occur in the hospital, nursing centers, home, and we provide care at any stage of illness. So this could be anyone with a curable illness, where the serious illness is impacting their quality of life, or someone with a life-threatening or terminal illness. So just know that is what I do for a living. And one of my areas of expertise that I've dived into is serious illness conversations and how we can make the most of an effective conversation with patients and their families. So I'll share a little bit about that today. So I'm going to first talk what is serious news and how do we share it. So first, I just want to start with some basic definitions for all of us to be on the same page. So when we think about serious news, it is medical information that has the potential to impact how a person thinks about their future. You'll notice that serious news isn't bad news. Serious news can also be good news or neutral news. So I just want to highlight that serious news just is something that has potential impact on how a person thinks about their future. And what is prognosis? Well, prognosis is the science of estimating the likelihood of an outcome. This is not guaranteeing an outcome. This is the likelihood of an outcome. And I want us to think about that definition as we talk a little bit further about prognosis. So I'm going to ask the question out loud, why is sharing serious news and prognosis important? Well, we know from the literature that it serves three purposes. The first is to provide context for medical decision-making. If people know where they're heading, they're better able to talk about what's important to them. So for example, if someone knows that their life is going to be limited with their illness, they may reprioritize what's important to them. Maybe they no longer want to prioritize living as long as possible, but they want to prioritize being with their family, for example. So that goes to number two. It helps patients to resort and reprioritize their goals. And that's why having serious illness conversations and talking about prognosis frequently can help patients and their families resort their goals as their disease changes. The other thing that it does, it helps patients and their loved ones prepare for the future. And these actually have been shown to be beneficial in the literature with many great outcomes. The first is that if we share prognosis early and often, we actually increase goal-concordant care, meaning that patients will get the kind of care that they desire as opposed to getting the kind of care that they would never have wanted. The second is actually when we talk about prognosis, we prioritize the goals and therefore we can improve quality of life and patient well-being. There often is less use of hospital resources, fewer hospitalizations and ICU stays when we talk about prognosis early and often. And more importantly, it reduces the stress for caregivers. When loved ones and family members are on the same page about prognosis, they are less likely to experience stress even after a patient dies. And finally, there's better patient, family, and coping with all of this. So clearly, talking about prognosis and sharing serious news early and often does help improve patient care. However, we still avoid sharing serious news. And these are two studies that were shown in different patient populations, cancer population, which we're talking about today. But I also want to share a little bit from the heart failure population. So they actually did a study in 2017 where they asked oncologists to be truthful or anonymous and asked them, do they ever not talk about prognosis? And 50% of the oncologists who responded said they occasionally to always withhold prognostic information from patients. They asked heart failure specialists, or they asked heart failure patients about their interactions with specialists. And patients with advanced heart failure said they were reported that they received little or no information about the prognosis of their heart failure. So clearly there is still avoiding, even though we know that talking about prognosis is important. And when we do share the serious illness or serious news or prognosis, we don't always do a good job. And in the literature, patients have reported that often we are confusing, we provide mixed messages, or we just avoid it altogether. And here's an example of confusing. This came from a study from Tony Bach, who is a GI oncologist at the University of Washington. And he had a study where he recorded conversations from several different oncologists. And this is what the oncologist told a patient. He said 2.5, you have 2.5 years after your transplant. Your survival is 2.5 years after your transplant, and it stays level off after that. And it's about 30% in your situation. We have a few options for treatment. Let's talk about the possibility of stem cell transplant and the possibility of cure. I don't know about you, but I can't figure out, is 30% the survival rate? Is it 2.5? What is he trying to say there? And mixed messaging or avoiding also occurs. And this is a really great article that was published in JAMA that was Amanda Fantry, who's an emergency room physician. Her brother got into a serious car accident, and she entered a family meeting where the neurosurgeon gave prognosis. And she talks about how mixed the messaging was. And she knew that her brother was not going to survive based off of the injury and what was happening. But when the neurosurgeon conveyed the news, her mother misheard it. And I'll give you an example of what Amanda shared. She said, and soon both the neurosurgeon and the nurses were adding some ands and buts in order to soften the harsh discussion. And she mentions at the end of the discussion, her mother says, so he's gonna be okay. And Amanda realized that her mother did not get the same message. So I'm gonna ask the question, why is it so hard for us to share serious news? I'm going to do this as a poll. And I'm going to ask for you to think about your own personal reason why you don't share news or why it's hard for you to share news. Great, so we're 50%, 60%, give another 30 seconds. All right, end the poll and I'm gonna share the results. There is no clearly common answer for all of you. It looks like some of you picked, I don't wanna take away hope. Some said, I don't wanna make someone upset. Someone said it's someone else's role to deliver the news. Others said, I'm not sure what to say. Others are worried that they may get the prognosis wrong. And a few of you said, I don't have enough time. And you are all not alone in these answers. And in fact, you'll see that in many studies, these were the common answers. that people were worried about how to prognosticate or even get it wrong, or people were worried about taking away hope. And this is actually the number one reason in the pediatric literature of taking away hope, if it's serious news that is on the negative side or life-limiting side. Fear-provoking emotion. A lot of people are saying, well, it's the primary care physician's role, or it's the specialist's role, or it's the palliative care role. And then all of a sudden, no one actually is saying it. Unsure what to say. There actually isn't a lot of formal training in this. And then afraid patients don't want to talk about it. No one really picked on that, or I didn't give it as an option, but that is another common one. And then no time is also another common one as well. But patients actually do want to know the prognosis. And we know in the literature that comes often, or is frequent. Patients really do want to know truthful information. They want it direct and truthful. And this is a study that was published at Health Affairs. And this actually, from the Kaiser Foundation, they actually interviewed people from around the world and compared what people from Japan, Italy, US, and Brazil thought about serious illness conversations. And one of the questions was, would you want your doctor to be completely honest regardless of prognosis? And you'll notice in the US, 88% said be completely honest, and 3% said honest with hope, and only 7% said emphasized hope. And actually, when you ask the 7% more about that, the 7% will say they don't really want to hear it, but they want you to be truthful with their family members, so their family members are prepared. So even that 7% still want truthful information, but want it given to someone else. And the other issue is that patients don't want to bring up the conversation themselves. They want us to initiate the conversation. And so that's really important for us to know, because we maybe have to be the first ones to be, would it be okay if we talk about this? Because often we avoid it, they avoid it, and then all of a sudden we're not talking about it. And the other piece that patients say in the literature is that they want prognosis with a human connection. And there was an article that came out in 2019 that was about a telehealth encounter. This is way before COVID, but it felt as if the family was just getting serious news through a person, where they said it was a robot, where it was a person delivering news who they never met and did not feel any connection. And this was sort of a photo of obviously they didn't put the white coat there, but it felt to the family that it was this robot and inhuman thing. And they really wanted news to be shared in a kind, caring way with a human being. Sometimes we have to do it over telehealth, and we can talk about ways that we can do that. So for today, we're going to walk through how to deliver serious news in a compassionate and clear way. So how do we get started with serious news? And the thing that will remind us is that goals are informed by the news that we give. Again, patients need to know what ballpark they're playing in and what their boundaries are in order for them to make informed decisions. So it's always important to give prognosis or talk about news before we ask them what's important to them. So I'm going to ask this question: who would be an ideal patient to share serious news with? I'm going to launch this. Who should you share prognosis with? Which of the following patients? Fantastic. I'm going to end the poll, and I'm going to share the results. And you'll notice that most of you picked all of the above. And you are absolutely right that all of these patients at each of these times of their illness would be a good time to share prognosis, knowing that your prognosis or your serious news would change depending on what fork in the road you're at. I loved that some of you picked just at the time of diagnosis. That's so important to make sure you're on the same page, but also thinking about those other branches in the illness, or branches in or forks in the road, I should say. And so when you think about when to share the news, certainly really important at the time of diagnosis for cancer, when treatment works or doesn't work, and how the next course might look like and what that means for their illness. Whether there's a complication or a setback, really important. If someone's septic, has their functional status has changed, all those pieces, also important to bring back. Hey, remember we talked about prognosis, a couple of months ago, knowing this news that's going on or knowing your functional status, here's where I think we're at. And certainly when there's transitions of care setting, so if someone goes to the ICU, or someone goes to the hospital, or someone goes to rehab, those are also times to do it. And what I would certainly say is, we all know that making decisions or having a serious illness conversation in a crisis is a lot more emotionally charged than when things are going well. And so it's always important to remember it's really a good thing to talk about prognosis when things are going well, so that patients and their families have time to process than doing it in a crisis mode. So if we're going to bring up prognosis with a patient at the time of diagnosis or during a fork in the road, here's some steps to think about how you can prepare for the conversation. First, make sure you identify who you're giving that, and you can think about, if it's general or prognosis, and how do you prioritize, because you have all these patients that you're working with. You can say, who would I be surprised? Who would I not be surprised that an event happens to them in the next year? And those patients you could actually prioritize first to have these conversations. Make sure you gather the data. Make sure you discuss with other members of the team to make sure you're on the same page, right? Are we on the same page about prognosis? I'm worried about this patient. Is this other provider worried about this patient? And then make sure you carve that time. Now, serious illness conversations in the literature have been shown that they can be done in 18 to 20 minutes. Obviously, the more emotionally charged, it may be a little bit longer, but setting aside 20 to 30 minutes for this is sufficient enough. And finally, you want to make sure that the patient invites those people that can help support them. And you could also make sure that if there's any specialists or people a part of your team that you feel like should be there, make sure that they come as well. And if you're doing it via Zoom, make sure, or through a video, make sure you have a technology check-in, make sure the patient knows how to use the technology of the telehealth. So how do you invite the conversation when you're with the patient? And the best way to do that is just calling out that you want to talk about the future of their illness. So here's a line from the serious illness conversation. I'd like to talk to you about what is ahead with your illness and thinking in advance about what is important to you, so that I can make sure we provide you with the care that always keeps your goals in mind, or keeps what's important in mind. Would that be okay? So just thinking about, how do you invite that conversation? What if there's pushback? What if they're like, yeah, no, don't want to talk about it now? Well, there are 3 routes you can do, and you could do all 3 if you wanted. You can normalize and say, this is something I do with my patients. As long as you actually do it with all your patients, you can definitely normalize it. You can explore why they're hesitant. Can you tell me why you're hesitant to talk about this? You can rationalize or say, these conversations are really important to do when things are going well, so that we can take our time to think about some of the decisions moving forward. So then if they say yes and they're ready, you have the right people in place, you can then think about how you share the news. And before you share prognosis, you want to think about 3 ways to assess them and their understanding before. So first, assess their understanding. Where are they at? This is really important because you're going to fill in the gaps. So if you are in a huge difference with your gaps, you're going to have to fill in more than if you're on the same page. So a way to do this is, what have you been told about your current medical condition or your current cancer? What is your sense of how things are going is another way of getting that perception. The other important ask, and you don't have to do this every time, unlike understanding, which you should do every time, even the next day, I'll always ask understanding. But information preferences are helpful when you're going to first start a relationship, and ask them, how much information about what to expect with your illness would be helpful for you, or what information would you like to know about your illness? This really helps when people who are like, I just want to hear good news. I don't want to hear details. I just want big picture. That can help you cater your prognosis. And the final thing is making sure they're ready. And this is just asking, would it be okay if I share my understanding of what lies ahead with your illness now? Because if they're not ready, or if they're emotionally still charged, you could say whatever you want, but they will not hear you. And so it's really important to keep that in mind. Now, if you notice there's a big gap, it's important to label your news, and labeling gives them a little bit of a warning that this is really serious news. Now, you'll notice I didn't say we're going to say this is bad news or I have bad news, because sometimes what we think is bad news may actually be good news for a patient. I hate to make assumptions about whether something's good or bad, because you actually never know what they're feeling. So, for example, metastatic cancer might actually be a relief for a patient because they've been searching for an answer for so long. So often I'll just say, I have serious news, I have difficult news, I have important news, in a more neutral way for labeling. Now, certainly if you're used to the labels, or your patient and they said, if my cancer worsens, that's bad news, you could use the word bad. So how do you share the news? Well, in Vital Talk, which is an organization that teaches serious illness conversations, and also in Talk Vermont, which we lead here locally, we think about sharing news in what's called a headline. So I'm just going to talk a little bit about what is a headline for a newspaper. And so, a headline, as we all know, is something that catches our eye and summarizes what's down below in the news article. So, for example, for this one, 1,500 dead in Hawaii, Congress votes war. But what's also really interesting about a headline is it not only summarizes what is in the article, but what it means to the reader. So, for example, 1,500 dead in Hawaii is the summary of the event. Congress votes war is more about the aftermath, or what it means for the reader. I'll give another example. So Nixon quits, again, summary of the information. In the interest of the nation, more about meaning. Or again, Berlin Wall tumbles. Again, that's the summary of the event. Beginning of the end of communism, the meaning for the reader. So when we think about medical headlines, we think about making sure that it's 1 to 2 sentences. That is the take-home message. So this is the thing that you want the patient to leave the conversation with to tell their family. We want to minimize jargon, and we want to make sure it's at an understandable 5th grade level. So again, meaning, or in summary of the information and meaning, 5th grade reading level, no jargon, and 1 to 2 sentences. And I have all those there. Really important to be impactful. Often we give headlines where we say the cancer has progressed. But what we don't always do is put the meaning. The cancer has progressed. And this means that we're concerned that you could die in the next year, because that meaning will help them think about their goals and their priorities. So let's think about types of headlines that are out there. So when we think about prognosis can actually be in 3 buckets. The first is a time bucket, which I think all of us think about, and this is time to mortality usually what people think about. And this is thinking about time, and what we like to say, give a range for time. I'm concerned that given the state of your cancer, you could die in it as short as weeks to months. But sometimes it could just be about cure or death, or a major event. So for example, the results of the test show that you have breast cancer, that it's spread to your brain, and unfortunately this cannot be cured. Or it looks like your mother has a severe infection on top of her cancer, and we're worried she could die of this hospitalization. But another form of prognosis could just be about functional ability. And so an example of that could be, given how deconditioned your mother is from the last round of chemo, we believe she will not be able to return to her previous abilities to walk and be independent. So again, that's just another different kinds of prognosis. It doesn't always have to be about time. And the other caveat I want to say is, often I'll hear physicians say, I don't have a crystal ball. And what I will say out loud is, patients know we don't have a crystal ball. We do not need to say the obvious. Often we say, I don't have a crystal ball, not for the patient's sake, but for our own sake. And what I want all of you to think about is, you have expertise to think about prognosis, and you actually can give an estimate of what you think is going on. So you could use ranges, as I said, weeks to months, that allows for some error, or months to years, or as long as a couple of years, for example. You could say what you're worried about. So if you're not sure how long they're going to live, but you're worried that an event will happen in the next year, you could say that, I don't know what's going to happen in the next year, but I'm really worried that you will have a setback with your cancer this year. And the other piece that you can share is, be honest about your uncertainty. And so if you say, certainly, generally someone with this cancer will live about the next couple of years, but patients surprise me sometimes and either live shorter or longer than that estimate. So some of you mentioned this is not your role, and it may not be your role. And so the thing to think about, help out your colleagues when it comes to this. So if you're in the room and a colleague is not giving a headline, and your patient, you see a patient or their loved ones just sort of not understanding or getting confused, you can insert the prognosis headline by saying, so it sounds like X. We are worried that, you could die in the next couple of months. If the headline was delivered prior to your conversation, you could go ahead and actually deliver, especially if you're on the same page with the other colleagues, ask the patient what they heard, ask permission, can I share, and then said, I heard that this is your prognosis. And again, we all mess up. We all sometimes dance around the prognosis. And so having colleagues come in with us to help support us so that we can be open and honest and clear can be helpful. So let's practice a headline. So this is Paula. She is 43. She has hypertension, tobacco use. She has a history. She's presented in the hospital with chest pain and shortness of breath. CAT scans showed lymphadenopathy, a large mass in her lungs, and bone lesions in her spine. Biopsy of the mass revealed stage 4 non-small cell lung cancer. Oncologist says her cancer is incurable. So I'm going to launch a poll and ask all of you to think about, what is Paula's medical summary? So remember, headline has two parts, a medical summary and what it means. And so first, we're just going to talk about, what is Paula's medical summary? Thank you all for who responded. We're at 60%, so I'll end the poll and share the results. Majority of you picked, the imaging showed that you have cancer in your lungs that has spread to the bones. And that is great, because it takes not only the large mass that was discovered in the lungs and that was confirmed by biopsy, but that it has spread. So it's an advanced cancer. Some of you also mentioned you have found a large mass in your lungs, which doesn't include the spread. So sometimes it's important to make sure that you include the other pieces. Some mentioned metastatic small cell lung cancer. It is important to name the disease. Sometimes I'll actually describe it before I name it. So just something to think about as you're doing this. And your cancer cannot be cured. We'll hold that thought for a moment as we think about the next step. So my next question is going to be, what is the meaning for PAULA? What does this mean for her in her cancer or her life? So this one is a little bit harder to decipher the meaning. And so the best answer here is your cancer cannot be cured, and this means you will likely die from your cancer. It gives the meaning of what the cancer is going to do to her or for her life. Now, what I will say is your cancer is now advanced and will progress is actually a meaning, but what's missing there is, what does it mean advanced, or what does it mean progress? Some patients and their families may not know what those words mean. And so it's important to actually describe what is progress or what does advanced mean. The other piece is, your cancer is not curable. Great, that's a great meaning, but we have chemotherapy that can help you. That confuses the message. And what often I find when I was first doing serious news, I would stick treatment plans into my headline. And what we don't want is treatment plans in the headline, because sometimes patients might actually say something that may not want to be about treatment. And so it's really important that they hear the news and what it means for them, and then talk about treatment options. And so I tend to keep treatment options out of the headlines unless the treatment option is the thing that's causing the problem. And again, your cancer is really bad is quite vague. And so avoiding that, those vagaries is important. So I'm going to give you another example, and I want you to put this one in the chat feature. So Joe is a 45-year-old woman with metastatic lung cancer to the bones on immunotherapy, walking into clinic today. Surveillance CT scan shows new bone mets in the lumbar and sacral spine, increased hilar lymphadenopathy, larger lung mass. And now her oncologist feels that her chemotherapy would not likely benefit her or control her cancer. So I want you to think about in the chat, what would be the headline you would give her that would summarize her disease or summarize the info and add meaning. So we're going to actually put it together. I'll give you a minute to think about that. And when you're ready, you can type in a headline that feels comfortable for you as I pour my coffee. Thank you, Connor, for going first. Anyone else have a headline? Great. I love all these examples of headlines. Thank you. All of you are mentioning that you're saying there's new cancer or progression of your cancer, and it's spread or discovered in your spine now. And then you're all saying that further chemotherapy will no longer benefit you or help you. I love Mara, immunotherapy is not working. Yes. So even giving the headline and just saying things like, you know, the CAT scan shows that the new bone metastasis, that there is new spread to your cancer, and it looks like the immunotherapy is no longer working. And we're worried that more chemotherapy will no longer control your cancer. So just thinking about that piece, or no longer will help you or will help you feel sicker. I think someone mentioned about the well-being or your welfare. So great job with that. I think I have the CAT scan results show the cancer is worse despite the immunotherapy, and we worry that more chemotherapy will no longer control your cancer. Great. Thank you all for your headlines. So important to cater your headlines to their gaps. So if Joe says, I know my cancer is worse and I will likely die from this, you do not need to repeat what we just said. You could say, I heard that too. And then you can show empathy. I wish things were different. But if Joe says, she says, I'm hoping for a cure, it's probably just something minor, you know you have to give a little bit more. And you may give a label, well, I have some difficult news to hear. And then you can say, we did a CAT scan and it shows progression, you know, of your cancer despite the immunotherapy, and then share those pieces. So just know that you cater your headline depending on what someone says. And here are some common headline snafus that we all do in medicine that to think about to try to avoid. One is what I call the obvious headline, which I'm trying to see why this is, whoops, I think I had like a little bit of stall here. The obvious headline, and here's a headline, rooms with broken air conditioners are hot. Yes, that's right. Hot rooms don't have air conditioners. And I always say this is something like your mom's really sick and, you know, she's in the ICU and has, you know, metastatic cancer. Yes, that is obvious. We do not need to say the obvious headline. And so think about what is the objective you want to say? What does it mean that her mom's really sick? The other one is the misleading headline. Students cook and serve grandparents. We know what that's trying to say, but it also sounds like there's something else going on with this headline. And so thinking about how we can be clear with our language and really be thoughtful. What does it mean? There are no more treatments. Well, you know, with someone with metastatic cancer, we may not have treatments that control the cancer, but we may have treatments that can help them with their symptoms. So thinking about the choice in our words can be helpful. And the final thing is the confusing headline, damn nearly finished, but much left to do. No, thinking about how we can not put the ands, the buts, or chemotherapy could help, and being very clear about our language. Now, it's really important after the headline, just stop and let them process and have emotion. Now, if they don't have emotion or you're not sure they get it, you could always check in with what's called a second ask. You could check for their understanding to make sure I did a good job giving your information. Tell me what you're going to tell your spouse about your conversation. What's your takeaway? That's a teach back that we see in other things. And the final piece is emotional check-in. How are you doing with this information? Now, I'm going to quickly go through expect emotion or respond to empathy, because having emotions might actually be a good thing, because that shows that they actually are processing the information. And so the first step in having emotion or responding to emotion is noticing it. You'll notice this provider is not noticing the emotion in the room because they have their back turned to them. And so when a quality headline is delivered, there will be emotion. And I just wanted to share this story about Emily, who is a 35-year-old woman, Hodgkin's lymphoma, status post-radiation therapy and chemotherapy 5 years ago, presented in the emergency room last week with fatigue. She's found to have pancytopenia. After blood transfusion and a bone marrow biopsy, she was sent home. She's confirmed to have a diagnosis of AML. And she is set up with an oncologist to discuss the next steps. And I'm going to bring us back to the oncologist who we met before. Emily was asked before she went into the room to speak to the oncologist, Emily was asked what she thinks of her possibility of cure. And Emily said 90 to 100% chance of cure. So the oncologist then tells her news and says, in people with your type of leukemia, the survival rate for 2.5 years after treatment is 30%. Knowing this, we have a few options for treatment. Let's talk about the possibility of stem cell transplant and the possibility of cure. So my question in the poll for all of you is, what do you think after she hears this news, what you think her interpretation of her chance of survival is now? What do you think her interpretation is, chance and survival is now? Excellent. Wait till there's 60%, nearly there. Excellent. So, majority of you actually said 30%. And some of you, though, said 10%, 60%, 70%, 90%. So a little bit all over. So we're going to find out more from Emily. And this is what she tells the nurse after 1 week after the appointment. She says about the oncologist, after he said the 30%, he just kept dinging along on his facts, and I was stunned. Literally, my note-taking was completely done. All I wrote was 30% the rest of the time all over my paper, and I mean, I just couldn't get past that point. I don't know how to describe it. And so I'm going to ask you one more time, hearing this, what do you think her estimate is now? Fantastic. I'm gonna end the poll and share the results. Most of you said 30%, but none of you actually, most of you, everyone lowered their estimate to be at least 50% or lower. And actually, this was a study, and they asked her what she thought, and she said 90 to 100%. This is really interesting because even though she heard the 30%, she was actually still thinking 90, 100%. So it did not sink in. And this really illustrates how emotions can hijack cognition. And so we could all do a really good job about giving prognosis. And when emotion happens, it blocks that information. And so what's really important to think about is, this emotional hijack of the limbic system over the prefrontal system. And it's so important for us to acknowledge emotion so that we can help calm the limbic system and invite the prefrontal cortex to process the information. So after we deliver news, we should respond to the emotion, acknowledge it, name it. And this helps build better connections, builds trust, and gain understanding for patients' values and beliefs. So I'm going to stop there. And I'm going to take questions. Oh, one thing to note is when you actually respond to emotion, there is good data when clinicians attend to emotions and then stop and not explain anything further. Family participants have time to express emotions and provide valuable information. There's a great study that was in the pediatric ICUs that showed that. But I'm going to take questions and see what is on your mind from that talk. And I can stop sharing my screen. You can put your questions in the chat, and Catherine and myself we'll find it and answer it.
Thank you so
I could
much,
also,
Dr. Berns. While we wait for questions to come in, I am always curious to hear what drew you to this work.
yeah.
Yeah.
I will say that when I was a resident, and I actually wanted to be an oncologist for the longest time, and when I was a resident, I noticed that we were terrible at delivering news or terrible at responding to emotion. And I remember when a palliative care physician, we were telling him this patient was ignoring us. She didn't want to speak to us. She had metastatic, she had actually a gallbladder cancer and just wouldn't want to talk to us. And he said, oh, I'll go talk to her. And we went in with him. And like, seriously, in 3 lines, she opened up to him. And I was like, wow, this guy is amazing. I want to be like him. And so I recognized that I wanted skills in high quality conversations. And that's sort of how I got into this work.
Thank you. Gwen, I see your hand up, so why don't we start with you, and then I see 2 questions in the chat we'll do after.
Okay, perfect. Thank you so much. And thank you so much for this talk this morning. It is early, but it was really great. And I'm a social worker, and I have ended up having a niche of work where the physicians in the Northeast Kingdom where I live are sending me their elders. I think it's because I'm elder now. And anyway, so a lot of folks have prognosis. And this has been really helpful for me. I touch base with a lot of elders who live alone, who have, for instance, Parkinson's, who have MS, et cetera. And so I think, I don't know if it's a question or a comment. I know this is going to really direct my way of interacting with people. I try to slowly move them towards planning. It's very difficult. A lot of times people are living alone, don't have family or friends nearby. This is the NEK, and people kind of, want to be alone. So this conversation that you led this morning is very helpful. I was just texting one of the primary care physicians of how we can help DE really kind of understand the complexity of a situation given his diagnosis of a progressive neurological disease. So I don't know if there's a question there, but lots of gratitude. Thank you so much.
Oh, I appreciate that. The one thing I will actually mention a little bit is this really interesting piece about if someone has lots of comorbidities and it's mixed, they have cancer, but they have other things. There is this, UCSF has this program called PROGNOSIS, which is based off of lots of literature. You could actually, they have a bunch of different calculators for patients who live in a nursing home or patients who live at home or patients in a hospital. And you could actually get estimate survival from those calculators. It's just really helpful to think about someone's overall gestalt. And so it's actually, they include like their renal function and the heart function and cancer diagnosis. So I find that really helpful for overall picture, especially if you're not sure where to begin with a patient. So thank you, Gwen, for that comment.
Thank you.
Christina asks, how do you handle a patient or family who continue to deny the reality of a prognosis? It's a great question.
Great question. So my 2 hypotheses are either, is this an emotional block or is it a cognitive block? And I will say 99% of the time, it is an emotional block. It's usually some sort of emotion so what I always do is just respond to the emotion and explore the emotion first. I find if I explain it over and over again, doesn't really work. And it's sort of like beating them over the head. You have cancer, you have cancer. The one thing I will say is though, sometimes going to the what if place is helpful for patients. So if they say, well, I know I'm going to be cured, you can say, have you considered a possibility if you don't get cured? And see if they can go to the what if space, because sometimes they'll go to the what if space with you, the imaginary place, and then you could sort of talk about their goals and priorities there.
Great, thank you. Briefly, before we move on to the next question, Linda asks, what is or Mara asks, can you repeat the name of the predictive tool?
Oh yeah, ePrognosis. I'll put that in the chat. ePrognosis from, and of course, spell check and change it. ePrognosis from UCSF.
Mara asked, for the individual where the immunotherapy is no longer working, what would you say next? And you have X amount of time. We need to start looking at life planning. She can't think of what to say.
Yeah, so great. So good. So how do you branch over to goals? So what I would certainly say is yes. So delivering the news, despite the immunotherapy, your cancer has progressed. And I'm worried that any further chemotherapy will no longer be able to control your cancer. Or I'm worried that this means that you will die in the next, and depending on the patient, the functional status and all sorts of things, but thinking about the prognosis, you could die in the next year. And then after you respond to emotion, I will then say something like, can we talk about what the future looks like and what the next steps could be? And then if they say yes, then I say, knowing this news that I just shared with you, what do you want to prioritize? What is most important to you? What are you worried about? And all those things, I always remind them of the context, knowing what I just shared with you. What are you worried about? What is most important to you? And when I get lots and lots of different goals and priorities, I can take that and then provide a treatment plan with them. Hope that answers your question, Mara.
And I think that touches on Amy's question as well. So I'm going to move on to Jennifer's, which is a comment and a question. Our doctors are horrible at talking to patients about prognosis. How can us support staff deal with that?
Yeah, this is really important to recognize. We hate to cause harm, emotional harm to people. We're in this business to make people feel better. And so what I would certainly say is we avoid it. We don't want to go in that room. And so know that that's a human thing. So one is acknowledging the emotion of the physician who's not sharing the prognosis is important. Wow, I noticed how much you care about this patient. I'm noticing how hard it is to share the news with this patient, especially if they, sometimes people share the news behind the closed doors, but when they're actually in the room, they don't, which I'll often see that. But then the other piece is saying, can I share with you my worry about this patient to the physician? I'm worried, or I'm seeing that they look like they're sicker. Do you share that? So sharing your headline with them can often bring them to your headline.
This is great. And I think we have time for one last question before our next session at 8:30. Linda asks, what is the role of touch in talking with patients?
Oh my gosh, we could probably talk about this for 10 minutes. So the bottom line I would say is therapeutic touch is important. And just like how there's consent in relationships we have, you want to make sure there's consent together. And you want to make sure you're comfortable with it. I once had a palliative care attending who was so awkward at hugs, he should not be giving out hugs to patients. And so what I would certainly say is do what's comfortable with you. And if you cannot read what a patient, like whether or not touch that's appropriate, ask, is it all right if I hold your hand? Is it all right if I touch your shoulder, right? Asking permission can be helpful. We also know that they're, arms, shoulders, great places, but in hands, but pretty much everywhere else is not good. I once had a resident who would pat a patient's head, and the patient told me I felt like a dog, and making sure that you don't touch anyone's legs, as obviously you know, but I think the bottom line is do what feels comfortable for you and read the room and ask permission.
Wonderful. Thank you all for joining us this morning. Thank you, Dr. Berns. This is great information. And I believe the links to our next session are in the chat. Have a great day, everybody.